Yes.
Welcome everybody to this faculty lecture on management of thyroid cancer. I will be sticking to management of well differentiated thyroid cancers because the others are rare, and I think this itself is a very big topic. Coming to the incidence, the thyroid cancer is has tripled in over the last 30 years, mainly because of the increased detection rates, and it is the most common cancer diagnosed in women, fifth most common cancer diagnosed in women, and there is a male to female to male preponderance of about 3 is to 1, and 95% of all the malignancies of endocrine organs is uh, attributed to thyroid cancer. The incidence of thyroid cancer is increasing due to one, surveillance and excellent ultrasound neck thyroid, and also ultrasound guided FNAC. So if you look at this slide here, you can see the incidence of estimated new cases in 2024, and thyroid cancer is about 44,000, and with the 2,000 death rate also, and there is a it is forming about 2.2% of all new diagnosed cancers, and there is a constant increase also. If you look at the 5-year survival that has been reported, and you can see that there is a 98.4% 5-year survival between the years of 2014 to 2020. Out of this, if the tumor is localized to thyroid, it is 99.9%, which is almost 100%. If there is extrathyroidal extension or regional nodes, it will be 98.2%, still excellent. If there are distant metastases, suddenly it drops to 51%. And if the metastatic and this one is unknown, still there is a 5-year survival of about 92.7%. So this is the, so it still is one of the best cancers to have, if at all you have to have it. Coming to the anatomy, as you can see, the thyroid on either side, that is the anterior and the posterior aspect of it, the parathyroids are there. They are not always classically, there as they have been denoted there. But, just to give you an idea of how thyroid hugs the tracheal rings, and the extension is up to the lower part of the thyroid cartilage, as you can see here. Coming to another important aspect of the thyroid anatomy is the Berry's ligament, which is one of the most important pointers for the recurrent laryngeal nerve. This is the recurrent laryngeal nerve triangle, which is formed by the carotid artery and the inferior thyroid artery, and the recurrent laryngeal nerve itself is a border. So it forms one of the borders, and this is the Berry's ligament. So that you have to be careful where the thyroid is attached to the tracheal rings, so and the cricoid cartilage. So you have to be extremely careful in that region. Now, just another aspect of the recurrent laryngeal nerve and the other nerves of the thyroid. As you can see, we always talk about, let us just concentrate on the superior laryngeal nerve. As you can see, if you go away from the gland, they are almost abutting each other. The superior thyroid artery, which comes from the external carotid artery, and you can see the the. Can you see my pointer there?
Yes, sir.
Yes, sir.
Ah. So as it approaches the gland, the superior pole of the gland, you can see the nerve and the artery are quite far apart, which is why it is said that, of course, you have to be careful, but you have to ensure that you ligate the superior pedicle as close to the gland as possible, so that you don't injure or ligate the nerve along with it. If you see, it's slightly away, another 2 or 3 centimeters away, the nerve is completely, almost abutting the artery there. So similarly, you can see it on this side also. So if you ligate the superior thyroid artery close to the superior pole, you're less likely to injure the, and you can see the recurrent laryngeal nerve as it recurs round the subclavian artery on the right side and the arch of the aorta on the left side. So this is, again very important for us to know about the anatomy of the both the nerves. So this is the triangle I was talking about, the riddles or the Bayes triangle. You can see the recurrent laryngeal nerve forming the part of the Bayes triangle, inferior thyroid artery and the common carotid artery there. So this is the triangle there, and you can see the nerve going there. So you have to be careful in this region where the nerve traverses the tracheoesophageal groove and just medial to the carotid artery there. So this is again the incidence of the parathyroid gland. As you see, the superior parathyroid is more likely to be more stable in its position. About 80% of it is found in the nearer the upper pole, and if you look at the distribution of the inferior parathyroid gland, it is anywhere between 44%, which is the commonest, nearer the lower pole, but it can be near the inferior thyroid artery, close to the recurrent laryngeal nerve, and even sometimes in the superior mediastinum as well. So sometimes it can go up to the superior mediastinum or the suprasternal notch. So this is very important as far as the parathyroid is concerned. When you are doing surgery for parathyroid, not so important as far as thyroid is concerned, because it is important to preserve it, but by and large you will be able to preserve, you will be able to see a particular gland. This is the lymphatic drainage, which all of you know. You should know this by heart. All the triangles of the neck and the levels of the lymph nodes, and usually the level 6 and 7 is what you consider as the central compartment, and the lateral compartments. When the central compartment is involved, you have to sometimes even level 5 also has to be dealt with, but by and large it is 6 and 7 when you do central compartment, and sometimes if the lateral nodes are involved, then you have to go for 2, 3 and 4 in addition to 6 and 7, occasionally 5 as well. Okay, coming to the risk factors of carcinoma, one of the most important thing is the ionizing radiation in childhood. So this history is very, very important because it straight away puts people into the high risk category. And it is important for you to know this because if there is significant definitive history of ionizing radiation in childhood, then you are less likely to consider the more conservative approach or the wait and watch policy that you adapt in other well differentiated thyroid cancers. So this is one of the factors which you have to consider when you consider active surveillance of thyroid cancers. In presence of a definitive history of ionizing radiation, you should take the definitive route of thyroidectomy as opposed to active surveillance. Again, iodine deficiency or excess, high levels of TSH hormone, and genetic predisposition. These are the risk factors of thyroid cancer. Coming to the origin, from follicular cells, you have the well differentiated follicular and papillary, and then you have the poorly differentiated and undifferentiated or anaplastic, and from the parafollicular C cells, you have the medullary carcinoma of the thyroid. So what are the things that you have to do? I'm just running through these slides because these are important, but you already know about these things. Physical examination forms one of the most important facets of the triple assessment that we talk about, clinical examination. So clinical examination, you have to ask for history of dysphagia, voice change and swelling, and the progression of the swelling. Is there been gradual or rapid progression? Has there been any sudden increase in size? Then you have to ask for noisy breathing, chronic cough, signifying pressure on the trachea, and then change of voice, signifying pressure on the recurrent laryngeal nerve or infiltration, and dysphagia if there is infiltration posteriorly towards the esophagus. So that is the physical examination. You have to concentrate on examining the thyroid itself, see how many nodules are there and the characteristics of these nodules, presence of lymph nodes in the neck, and then also presence of any metastatic deposits elsewhere. And I'll come to the imaging and fine needle aspiration. And the first investigation that you have to do is the TSH, and TSH levels will dictate which way you are going to investigate these patients. And in definitive history of either, if you're thinking of medullary carcinoma, obviously you need to get calcitonin level, serum calcium as a baseline, because post-operatively, if you want to monitor these patients, you have to have a baseline. And thyroglobulin, not so much, because thyroglobulin levels are only important in the post-operative monitoring of these patients. So ultrasound provides greater anatomic details compared to CT, MRI and radionuclide scanning. So this is one investigation where it is better than the more advanced CT, MR and radionuclide scanning. And actually they say if you have a very good ultrasonologist, you can actually see the histology of the gland. And because you use the 10 to 15 megahertz probe, and it is because the thyroid is very superficial, it is very easily accessible for diagnosis. But only disadvantage is you have to have a dedicated and interested operator, so it is operator dependent. And the goals of ultrasound diagnosis is diagnosis of the structural thyroid pathology, especially in non-palpable glands, and neck assessment, especially in terms of the neck nodes. And when you have multiple nodules, you may want to then identify the nodule which is most likely to be pathologic and give you the most diagnosis. So the guided FNA, especially, and also in patients who have cystic nodules, you want to aspirate the fluid and then under guidance and send it for cytology. So what are the features which are associated with the malignancy? When the margins are blurred or ill-defined or irregular, the halo and the rim around the nodule is absent, or if it is avascular, is irregular, spherical and taller than wider. Echo structure is solid. Echogenicity is hypoechoic. So hyperechoic nodules are less likely to be malignant, and spongy nodules are also less likely to be malignant, but they are intermediate. Compared to hyperechoic, spongy nodules are more likely to be malignant, but hypoechoic are the most likely. Calcifications, microcalcification, rim calcification, and internal calcification, what pathologists classify as Samoma bodies and the histology. The vascular pattern, hypervascular glands is always likely to be malignant. And then elastography, decreased elasticity of the tumor. This is the newer thing that has come in, ultrasound elastography and presence of lymph nodes. So this is the ultrasonologic picture. So if you see, this is a hypoechoic and there are multiple microcalcification that you can see in the gland, and you can see there is extrathyroidal extension. And margins, if you look at it, are it's not smooth, it's irregular, and the halo is disrupted. See, you can see the disrupted. This is again signifying extrathyroidal extension, increased vascularity in the gland, and then if you see the nodule is taller than it is wider. So all of these features indicate that this is likely to be malignant. So coming to the thyroid's classification, as you all know about this, TR1 is benign, TR2 is not suspicious, and TR3 is mildly suspicious. If the size of the nodule is more than 2.5 centimeters, you have to do an FNA. Otherwise, you do just follow these people up. If it is moderately suspicious, which is TR4, all these moderately suspicious, they have given the scoring accordingly: composition, echogenicity, shape, margin, and echogenic foci. All of these 5 characteristics are used to say whether it is mildly suspicious, moderately suspicious, or highly suspicious. So based on that, again, and the size of the nodule, if the in TR4, moderately suspicious. If the nodule is more than 1.5 centimeter, you do an FNA. If it is less than that, you follow them up. When it is highly suspicious, if it is more than 1 centimeter, you do an FNA. Otherwise, you follow them up. So this is the Thyroid's classification, which is one of the most significant things, that this is one of the risk assessment tools that are used now to differentiate between a benign and a possibly malignant thyroid nodule. So this is what I was talking about, elastography. The returning ultrasound echoes before and after compression are analyzed by software using a method termed as cross correlation to measure the tissue displacement, which is then used to form elastograms. And if it is mauve, it indicates that it's a soft thing. If it is red, then it indicates that it's hard. So harder nodules are likely to be more malignant. Next tool that they use is FNA. So it's the most useful diagnostic technique that is crucial for diagnosis and also for follow-up, and also as to decide about surgery. The selection of nodules. Now the latest guidelines have said you don't do any FNA in nodules less than 1 centimeter. So this should be clear to all of you. So if the nodules are nodule is less than 1 centimeter, you don't do an FNA. If the nodule is 1 centimeter and above, less than 1.5 centimeter, if it is highly suspicious on ultrasound TRADs, then you do the FNA. So that has to be very clear to all of you. And this one, based on the TSH and ultrasound, TSH, if the patient TSH is um, high, which means it is hypofunctioning gland, then the ultrasound, based on these two factors, you then decide on which nodule to. So if the TSH is high or normal, then only if the ultrasound is suspicious, then you do the FNA. If the TSH is low, which means the gland is hyperfunctioning, then you do a radionuclide thyroid scan, and usually you see the nodule will have a high uptake. So again, whether it's a hot nodule or a warm nodule, or the whole gland is taking up a radionuclide. So what this impresses upon is, if the TSH is high, then there is more likely that it may be malignant. If the TSH is normal, again it can be malignant. But if the TSH is low, which means the gland is hyperfunctioning, very little chance that the nodule is malignant. Though there are rare occasions where the hot nodules can be malignant, but they are quite rare. So don't diagnose malignancy in a hot nodule generally.
Sir,
So
Shrikant sir has asked a question, sir. Like, what are the
yes.
clinical indications for elastography in the chat box, sir?
So the elastography is when, for example, you have I don't know whether it is available across the board, but where it is available, what you can do is, when you are not clear about whether the gland is hard or firm on the ultrasound, and about the consistency, whether it is mixed, if it is a combination of hypo and hyperechoic or anechoic, then if you want to really understand the whether the gland is actually possibly malignant or not, then you can use elastography. Most of the time, all other characteristics will usually lead you to the diagnosis. Occasionally, when there is ambiguity or doubt, then you use elastography. So the current this one technique that is advocated is usually ultrasound guided FNA. So for the clear understanding of the students, it is important that if it is solitary nodule, obviously that nodule you have to aspirate. But if there are multiple nodules, you have to do an ultrasound and identify the nodule which is most likely to be abnormal, and then do the FNA from there. So the abnormality, as I told you, whether there is mixed echogenicity, solid, it's one hypervascular, taller than wider, all of these characteristics, irregular nodules, calcification inside, all of these characteristics you use to identify which nodule you have to aspirate. Then you give either a lidocaine analgesia or spray, and you use a 25 to 27 gauge needle, and probe in one hand and pierce and aspirate. It is usually said cytopuncture technique, that is the aspiration comes by the capillary action and the shorter dwell time inside the nodule. So as we said, smaller needles and rapid oscillations, you will get better yield. Occasionally, despite all of this, 5 to 7%, you will have a dry tap, or what we call as a dry yield, or inconclusive FNA. Then we may have to repeat it again. And you always make sure, for the benefit of all the students, younger students, you have to provide clinical information to the pathologist and the radiological information as well, so that they are able to correlate between clinical, radiological and cytological picture to come to a conclusion. So this is the Bethesda system for reporting thyroid cytopathology. Again, all of these are now standardized, which means the first one is non-diagnostic or unsatisfactory. Second is benign. Third one is ATP of undetermined significance or follicular lesion of undetermined significance. Four is follicular neoplasm or suspicious for follicular neoplasm, and five is suspicious for malignancy, which could be either papillary or medullary or even metastatic carcinoma, sometimes lymphoma. If it is lymphoma, as Niranjan said in the last class, that is one indication. If it is lymphoma, when you can't really conclusively prove that it is lymphoma, or if it is anaplastic, then you do a true cut biopsy of the thyroid. Otherwise, no role for true cut biopsy of the thyroid. So radionuclide imaging usually is reserved for the
What is the next
post-operative.
step if the FNS is unsatisfactory?
You will have to repeat the FNA. If you have to repeat the FNA once, and if it is still inconclusive, then depending on the risk factors and the ultrasound finding, clinical findings, then you may have to do a total lobectomy on that side of the nodule. And generally, the role of frozen section is, again, I think it's very debatable. I'll come to that later. So you may want to consider doing frozen section, but again, frozen section, there is about 7 to 10% incongruence between the final histology and the frozen section. So again, it is not fully conclusive, especially because of follicular malignancy, because they can't conclusively talk about vascular and capsular invasion on frozen section. So, radionuclear imaging is generally reserved for the post-operative status. But if the TSH levels are low, then that is the investigation of choice. So, if TSH levels are low, then you go for radionuclide scan. And then, if you see that there are hot nodules, and usually cold nodules are not, you may find a cold nodule, but then the TSH may not be. If the TSH level is normal, then you may find a cold nodule. So, but most important use of radionuclide imaging is after the surgery, you do a iodine 123 scan to see if there is any residual gland or any metastatic deposit. The risk factors. So these were all standardized before. That is ages, AMIS, and matches. Considering everything, the matches is considered to be this comes from the Mayo Clinic. Presence of metastasis, age, completeness of resection, local invasion, and tumor size. But these have actually given way to the new AJCC, 8th edition classification, and also the American Thyroid Association risk stratification, scoring. And hence, these are now no longer not much of use for these things. But when they were used, they were able to prognosticate fairly well, but better prognostication has come in, and with especially with the newer modalities and molecular testing and all that. So hence these are, you need to know this. That is why I put it up here. I think this PowerPoint presentation I'll share with all of you, so that you can use this information later. So if you come to the differentiated thyroid cancer, about papillary makes up about 85% of it, follicular and Hurtl cell 5%. medullary carcinoma 5%, and anaplastic 1.5 to 3.5%. So that is the ballpark figure. And so what are the high risk categories? So this is extremely important, and this has been derived from the American Thyroid Association. And so this is the the journal reference I have given below. And basically you have T stage 3A and N1, the nodes are more than 3 centimeter, and gross extrathyroidal extension and extranodal extension and distal metastasis. See, the problem with many of these high risk category is unless you resect the particular gland, I know one lobe of it, lot of these things you will not know. So that is the problem, especially if there is multicentricity, multifocal origin. All of these things cannot be actually made out on just any of the clinical examination unless there is multiple calcifications across the whole gland. So now coming to the latest HACC guidelines, 8th edition 2017. I don't think there is a 9th edition yet. So what happened was the prognosis of patients who had disease 45 up to 45 was considered to be the it was a poor prognostic sign, but that has been across the board with significant amount of patients in various multi-center and various randomized controlled trials, and data from the cancer registry has shown that the age, instead of it being 45, is now 55. So that this is one significant change that has happened since the 2017 8th edition. And the T3 now has been subdivided to T3 and T3b, that is presence of extrathyroidal extension and lymph node metastasis. And age, as I said, age above 55 with even if it is N1 node, it goes into stage 2. Level 5, 6 and 7 are considered a central group of nodes, and old patients with well differentiated carcinoma and lymph node metastasis straight away go to level 4B. And with this new guidelines, the tumors have been downstaged by 28 to 38%. What does that mean? Is that previously what used to be considered as high risk tumors have now been downstaged to intermediate or low risk tumors. So this is the significance of new HICC guidelines. So which means the prognosis of many of the patients has improved because they have been downstaged. Let me stop here. Any questions, any clarifications, anyone?
What is the role of PET scan in thyroid malignancies?
I'll come to that later, but very little role. Let me answer it straight away then. See, the PET CT is not one of the scans that is used for thyroid evaluation. However, sometimes when you use PET CT for some other reason, that is you are evaluating weight loss or possibly malignancy of unknown origin and things like that, then if you see a nodule that lights up in thyroid, even if the clinically the thyroid gland is not enlarged, and if there are neck nodes which again are not clinically palpable but lights up, then you will have to consider that one of the diagnoses could be thyroid malignancy if there are especially what we call as cervical lymphadenopathy of unknown primary. So thyroid is one of the things you have to consider if it is clinically palpable nodes or radiologically picked up nodes, then PET CT has only that role. And also other role for PET CT would be after in patients with medullary carcinoma thyroid, in patients with anaplastic and undifferentiated carcinoma thyroid, you could use that for monitoring the progress after nowadays because of the tyrosine kinase inhibitors, and some of them even respond to especially the undifferentiated for external beam radiotherapy and uh, image guided intensity modulated radiotherapy. To assess the response to treatment, you may use PET CT, but the role of PET CT is very limited in thyroid malignancy. The investigations in that order is ultrasound scan, CT for looking at the neck nodal and extrathyroidal extension, and so radionuclide scanning for assessment of prognosis post treatment to see if there are any residual tumor in the thyroid bed or in the distant regions. So these are the three investigations. PET CT has a very limited role. So going, if there are no further questions, any questions?
Does the differentiated cancers have extrathyroidal extensions?
Yeah, they can. They can have.
No,
Okay.
sir.
Right. So coming to the surgical management of differentiated thyroid cancer, see, the most important statement is this: you have to guard against under treatment in high risk cancers and over treatment in low risk patients. So this was the mission statement of the American Thyroid Association in 2015 and the 2018 guidelines. So this is the risk stratification that they have advocated. So there, unfortunately, as I said, there is many of these risk stratifications are post resection of the tumor. So that means you can also, of course, depend on the specialized ultrasound scan and the elastography and whatever that we are doing now and FNAC, but some of the risk criteria will come into post-operative status. So that means that you may have to then, depending on the final histology, you may have to risk stratify the patient. So that again becomes a slightly more complicated compared to other malignancies where risk stratification is easier based on investigations alone. So papillary thyroid microcarcinoma, which is less than 10 millimeters in size. So this is one of the things that has happened recently because of the brilliant investigative modalities, especially ultrasound. You have this scenario of, that over the last, from 2004 to 2018, there was a 3% year on year increase in the diagnosis of thyroid malignancies, and all of these could be attributed to the increased pickup rates from the ultrasound scan and FNAC. So that is why the 2018 guidelines of American Thyroid Association came in to state that any nodule less than 1 centimeter, you should not subject them to FNAC. So that was one of the ramifications. So beyond 2018, because of the new AJCC guidelines and the new American Thyroid Association guidelines, you have a decrease in the you have a decrease in the number of the incidence of thyroid cancer from 2018 onwards. So 2004 to 2018, year on year 3% on an average increase in the incidence, and since then there is a decrease in the thyroid malignancy incidence over the globe. So they have a lot of two significant studies, one including 1177 patients, um, out of which 755 were managed as active surveillance and 422 underwent surgery, and at 41 months there was a 9.6 progression. And if you look at them, the patients who are male, patients who are less than 30, and the size more than 6 millimeters, these were patients whom you could see more progression. So it goes against the grain that usually females have a poorer prognosis compared to males, or females definitely have more incidence also. But again, age less than 30 is a significant thing, and size more than 6 millimeters. So what it says is, if you manage these patients either by active surveillance or by surgery, there is no difference in overall survival or disease-free survival or cancer-related survival. So this shows that many of these patients, depending on their age and their accessibility to medical care and how well they are ready to be followed up and all these things, active surveillance is definitely possible. Another cancer registry data which shows to 1235 patients, the risk of progression is about 7.1% at 5 years, which is not actually bad. Only thing is that if you look at them, if you look at the two groups, that is one whom you have operated and one whom you have actively placed under surveillance, and those which showed progression and whom you operated, there is no difference in their recurrence rates, metastatic rates, 5-year survival, 10-year survival, and disease free survival. So, which means there is definitely a role for active surveillance, but this has to be only in papillary microcarcinoma, which is less than 10 millimeters. On the other hand, follicular and Hurthle cell tumors, more likely chance of hematogenous spread, and hence, you may have to be more careful with follicular carcinoma in terms of the active surveillance. So, what are the options? See, previously there used to be a flood of many kind of procedure for thyroid. Now the internationally recognized jargons are only two: total lobectomy, which is called TL, and total thyroidectomy, which is TT. So these are the only two terminologies that are now sort of in prevalence. So in terms of large retrospective studies have shown similar recurrence rates and overall survival in the low risk and intermediate risk groups of well differentiated thyroid cancers. That is, if you have a tumor 1 to 4 centimeters with no extrathyroidal extension and no nodes, please understand this carefully. T1 to T2, that is size 1 to 4 centimeters, no extrathyroidal extension as indicated by the ultrasound scan, and no nodes clinically or radiologically. You can do a total lobectomy and follow these people up. When it comes to T3A and T4, tumor more than 4 centimeters with nodal disease, extrathyroidal extension, and possible presence of distant metastasis, only treatment is total thyroidectomy. And then if there are high risk features, as I said before, radiation exposure in childhood, family history of thyroid cancer, and if you look at the cytology, if there are aggressive features in cytology, and on the scan, if there is multifocality and multinodular tumors, and as I said, extrathyroid extension on the scan, then even if they are smaller tumors, that is, when there are high risk features, it is better to offer them total thyroidectomy. So, if for example, you have, this is where this risk stratification comes in. So, as I said, many of the features are after the surgical intervention. So, if you have actually considered doing the lesser of the procedure, which is a total lobectomy, if the tumor finally on histology is more than 4 centimeters with positive resection margins, presence of gross extrathyroid extension, which may not be obvious on the scan, but on the histology it is there. And if there is multifocal disease, again, if they are micropapillary carcinomas, it may not be obvious on the scan. And if there are lymph node metastasis, again, the lymph node assessment of the ultrasound scan, if it is N0, it is about 81%. N1, it drops down to about 35 to 50%. If it is N2, again, it goes up to 92%. So there is some, sort of ambiguity and variability in terms of interpreting the nodal disease in ultrasound scan. So this is another reason where they say, even if it is a, if there is, if the papillary carcinomas are 2 or 3 centimeters with good prognosis, you may want to consider doing frozen section of and doing a one-sided center, depending on which side the nodule is. You doing one-sided central nodal dissection and sending it for frozen section. There are a few papers which are coming out which suggest that by doing a frozen section, it does improve the overall survival, but by 2-3%. but we are looking at, already a 90+% 5 years, 10-year survival. So the improvement is marginal, but if you are so inclined, it depends again on the how aggressive a surgeon is. Again, all of these things are, though they are all strong recommendation by American Thyroid Association and European, British, and all the thyroid associations, it ultimately depends on the, I think it is basically customization of treatment for thyroid cancer, depending on the individual patient and individual choice. For example, with the small tumors, one patient may find that he is not, or he or she is not bothered about going through lobectomy and then waiting for the final histology and then another surgery. They may say just get it done with one procedure. And then there are other people who are scared of surgery, who are reluctant to undergo surgery, who such patients would want to go through active surveillance, and you can follow that depending on the recommendations. And if there are high risk factors, then you have to warn them against going through the active surveillance. So that is how you counsel the patient. So it is, thyroid cancer treatment is now becoming extremely customized. So you have to tailor the surgery to the needs of the patient, the aspiration and the attitude of the patient, and also the ultrasound and the FNAC features and clinical features, of course. So, if for example you have, as I said, a tumor more than 4 centimeter with positive resection margin, gross extrathyroid extension, multifocal disease, presence of lymph nodes, even though it may not be obvious on the ultrasound, and if there is contralateral disease, vascular involvement, and small volume disease after radioiodine therapy, such patients you complete thyroidectomy. So coming to the recent trends, minimally invasive video assisted thyroidectomy or MEVAT, which was initially championed by McCauley in 1990, and then you have robo assisted transaxillary BABA and all that thyroidectomy, transoral endoscopic thyroidectomy. Current evidence suggests this is the 2024 benign and low risk well differentiated thyroid cancers can be operated by these modalities with equivalent complication and oncologic clearance. So the definitive indication, see, there are large volume centers which are breaking this, but if the thyroid volume is about 25 ml, nodule size less than 4 centimeters or 40 millimeters in size, large goiters, revision neck surgery, irradiated neck, locally invasive carcinoma, and lateral neck nodes. These are currently contraindications for minimal access thyroidectomies. Now coming to the thyroid, this one, radioiodine imaging and therapy. So basically, you should try to avoid using a full dose iodine 131 for detecting metastasis to prevent what is called as thyroid stunning. Because if you give a high dose, it can stun the thyroid and you may not get a representative value. So what you generally do is you starve these patients of TSH. So you don't give any T3 or T4 for a period of about 4 weeks. Then when the TSH levels are about 30 to 40, then the metastatic deposits or any residual tumor or residual thyroid gland will be hungry for iodine. Then you do the iodine 123. Unfortunately, in India we don't have the 123 isotope, so hence you use the low dose I-131. So once you have done that, if for example these are again risk stratification, as I told you, I've already told you what are the high risk. So if the high risk and intermediate risk patients, if the radioiodine uptake is there, then you give them iodine 131 therapy. So radioiodine ablation or radioiodine therapy is given. There is no
High risk means high risk for surgery, yeah?
ಇಲ್ಲ high risk for example tumor more than 4 centimeters, multicentricity, margins involvement, lymph node involvement, and histologically if the tumor is of high grade,
Oh,
all
very
of this
aggressive tumor.
aggressive tumor. So
Not
high
high
risk,
risk, not high risk for surgery.
not high risk for surgery for
Okay.
patients, not surgical risk, but histological and oncological risk.
Okay.
So high
Sir,
risk and yes,
Swarup sir has also joined, sir, just
yeah,
now.
good, good. So I think his features will come in the next few slides. So basically, high risk and intermediate risk patients, when there is radioiodine uptake, you then give them radioiodine therapy, but it is not seen to be beneficial in low risk and small volume disease, especially according to the 2015 and 2018 American Thyroid Association guidelines. So all the information I am giving you is based on the American Thyroid Association guidelines and the latest AJCC guidelines, and also the this one, the uh, see what is that, the other, what is that, NA, other guide, anyway I forgot that.
CN,
Huh?
NCCN, sir.
NCCN guidelines. So all of these guidelines are what I am giving you. So low risk and small volume disease, radioiodine ablation is not of much benefit. After, as I said, after 4 weeks of thyroid depletion, which is usually accepted as TSH being at least 10 times normal, initial imaging is done. The of iodine 131, because that is the only thing that is available here, you give it at 30 to 150 microcuries, that is, what is, gigabecquerels. Then if that is, this is the treatment dose. So if, for example, patients develop recurrence after radioiodine therapy, repeat therapy can be given up to a dose of 1000 microcuries. So this is about radioiodine therapy. Now coming to the newer things about genetic screening and the new immunology of thyroid cancer. With the papillary carcinoma, you have the BRAF V600E and RET and PTC, and this again indicates, if they are positive, it shows that the tumor is likely to spread locally, distant metastasis, and it will also, the prognosis is poor. With the follicular thyroid carcinoma, you have these are the, so I think it's difficult to remember, so that's why I put up the slide. And for the advanced thyroid cancer, again the BRAF V600E and all these things. So basically, all of these genetic testing that has come in, which will help to stratification, and also for treatment modulation. So if you look at this, you have the thyroid, follicle here, and in the tumor you see this DNA and microRNA, mRNA and microRNA changes that happen, the mutations, chromosomal variations, fusions, and alteration gene expression. So you have these molecular techniques called next generation sequencing, or the NGS, and the gene expression profiling. So this protein is actually tested, and the good news is that even this is now available even with the fine needle aspiration cytology, and you don't particularly need, it is good if you have a full tumor, but you can even do these molecular techniques with the FNAC. So there are these current nitrogen activated protein kinase. This is seen in the papillary carcinoma of thyroid, and phosphoinositide 3 hydroxy kinase PI3K, which is more common in follicular carcinoma of thyroid. There can be mixed expression of these, which indicates variants, papillary variant of the follicular carcinoma, or follicular variant of papillary carcinoma, and such like. So basically, based on this expression, you can risk stratify the patients. As I said, the BRAF V600E mutation and RAS and RET mutations. All of these, the positive expression of these mutations indicate aggressive disease, high lymph node metastatic rate, and higher rate of recurrence. So, as I said, when any of these are present, once you are able to, if you have the facility to do these things, then you are more advised more to go for a more aggressive treatment, that is a total thyroidectomy, rather than going for a total lobectomy, or even looking at active surveillance. If these are positive, then you are less advised to do active surveillance. You have to be more aggressive with these people. Now there are 3 diagnostic kits are available for this microRNA testing. I know I don't think it was relevant to put those names up because it will be, they are all commercially available in America. I don't know. Swaroop has to tell us, are any of these available in India, Swaroop, now? Hello, Swaroop?
Some are available, sir.
Okay,
There is a company called Foundation One. They actually ship it to the US to do it.
okay, so I'll let you the next 5 minutes or so. You can talk about the these current trends and how you go about it. So these are the things: gene expression profiling, point mutation testing, and next generation sequencing. These are the buzzwords currently, which will tell you the molecular techniques, which will tell you how you again help in risk assessment of these patients. So as I said, it requires minimal amount of DNA and RNA and can be performed even on FNA samples and paraphraging tissue samples. It allows to overcome limited sampling of the lesion and can be used for early detection of cancer. Next generation sequencing allows simultaneous analysis of multiple genomic iterations with high accuracy and sensitivity. So all of this will help you to profile the tumor better and then also focus on the treatment. So between the differentiated thyroid carcinoma and undifferentiated, you have high number of tumor-associated lymphocytes and regulatory T cells, and low tumor mutational burden. But in the undifferentiated, high density of tumor-associated macrophages and high tumor mutational burden. So that is the difference between the differentiated and undifferentiated tumors. So I have not gone into the management of, for example, radiotherapy, immunotherapy, chemotherapy, and all that, because that in itself we can probably have a next class dealing with the medullary carcinoma, anaplastic carcinoma, and also deal with all because they are more likely to be given for in the tyrosine kinase inhibitors and the various generations of them are more beneficial for medullary carcinoma and also for undifferentiated and anaplastic carcinoma. So I think we will deal with it later. So once you have a thyroid cancer, you have dealt with it. Follow up after the surgical treatment every 6 months, biochemistry, radiology, and based on the dynamic risk stratification. Here, as Shrikant's question comes, CT and PET CT can be used for looking at recurrence, especially if the if the high risk patients, and you have to do an ultrasound neck every 6 months and thyroglobulin to be done. And the thing is now I think so I'll let Swaroop talk about these things, but basically the previously the dose of thyroid suppression used to be quite high, requiring the TSH to be less than 0.001. And now that after in well differentiated carcinomas with good prognosis, I think after I think Swaroop can correct me if I'm wrong. After 5 years, you can reduce that to be between with normal TSH values could be coming down to minimally suppressive dose. So
Provided the patient comes for regular follow-up, sir.
yeah, provided the patient comes for regular follow-up. So these are the small changes that are happening. So now I will, I think we'll have time for questions also. I'll just let Swaroop just highlight some of the factors that I have actually just glossed over. Swaroop.
Yes, sir. Sir, first of all, I just want to make one point. For any patient of thyroid cancer who may eventually require radioiodine therapy, please make sure not to use contrast CT scans. Some of this iodinated contrast will saturate the thyroid gland and they will not uptake radioiodine.
Yeah, yeah.
Because that is one important thing. Because by default, we tend to do CT of the neck and they give contrast and the lymph nodes are visible. But later, when you send for radioiodine, for the next 6 weeks, they cannot use radioiodine therapy. That causes a lot of delay. Second thing is still, even now, even in metastatic thyroid cancer, surgery remains the mainstay in differentiated thyroid cancer I'm speaking about.
Yeah.
Because once we remove the thyroid and the lymph nodes, radioiodine therapy works very well to ablate the remaining tissue.
Correct, correct.
we should never think of radioiodine therapy as an upfront therapy.
Absolutely.
And first mainstay is surgery, then radioiodine, and the doses of radioiodine come into the domain of nuclear medicine.
Yeah.
Then the other things is external beam radiation therapy. It's especially useful in medullary carcinoma thyroid because they don't take uptake radioiodine.
So you can't use radioiodine therapy for medullary and even anaplastic carcinoma for that
Yes.
matter. Yeah.
For these people, external beam radiation therapy gives good local control, especially it prevents local recurrence in the neck and all those places.
Yeah.
However, if we say external beam radiation therapy, we can only give about 70 grays of radiation, whereas in radioiodine ablation, the effective dose are like 300 gray of radiation to the
300
tumor,
gray.
so
Yeah.
much high.
Yeah.
Then the other newer things like chemotherapy, immunotherapy, and all those things, they all come into the picture when everything else has failed.
Yeah.
So, from the surgical standpoint, from the DNB student standpoint, please focus more upon surgical aspects, the diagnostic aspect of how do we diagnose, what is the radioiodine scan, different isotopes of radioiodine which are used, and then radioiodine therapy, and then the follow up with how frequently you look for thyroglobulin and all those things you have to see. And in medullary carcinoma, you also look for CEA, those things you have to see.
Yeah. So
And yes.
just talk about the next generation sequencing, the latest genetic this one, which just a brief introduction, so to speak, of these things and how will they impact your risk stratification.
Honestly, sir, for thyroid cancer, it may not impact much. But for academic interest, we can discuss. Whereas in breast, lung, and other cancers, they have a much bigger role. In thyroid cancer, we already have a clear pathway as to what has to be done. So
Yeah.
we mainly look for BRAF mutations because we have something called dabrafenib and trametinib, which can be used against BRAF and MEK mutations. For all others, we have anti-angiogenic tyrosine kinase inhibitors such as axitinib, sorafenib, and all those things, which
Okay.
are having good effect in terms of prolonging the life without causing much toxicity.
Okay.
Immunotherapy is one thing which may be helpful in our
Anaplastic and
anaplastic carcinoma
medullary.
thyroid,
Medullary.
especially when combined with chemotherapy.
Yeah.
Uh, and regarding next generation sequencing, I'll just tell you what it is, how is it different compared to PCR. For example, if we want to do PCR for somebody with a particular cancer, we have to know what we are looking for. For example, I want to check for PIK3CA mutation, for which I am going to run a PCR for that particular mutation. Anything else will not be found out by this test. But when we do a next generation sequencing, we are going to look for multiple mutations in a single test.
Yeah.
Yeah, similarly, like in breast cancer, when we look for somebody for PRCA mutation, we only look for PRCA testing. But when we do NGS, we look for 150 to 180 different gene mutations. It is more economical and also more comprehensive. And it's called NGS because it's next generation sequencing. PCR was the first generation, now we have NGS. And it's evolving by the day. But unfortunately, some of them are hyped up, some of them are not clinically proven. But overall, the trend is good that we'll have better diagnostics in the coming years.
So questions, comments from the PGs and then the registrars. Nikita, questions?
Sir, no question, sir.
Ah,
Sir, it was an extensive class covering the clinical aspects as well as the complete evaluation, sir.
are you clear about when to use what and what surgery, everything? All of these things are clear,
Sir,
both
I think
from exam point of view and clinical point of view.
yes, sir, but we need to go through multiple times because at the end of the class, it felt little uh, uh, not confusing, but like
No, no, no.
little overwhelming, sir.
Genes are very difficult to understand.
Yes,
Huh?
sir.
Genes are it's difficult to
Ah, alla,
understand
alla.
now.
See, I think you should not worry too much about
Yeah, it is
genetics.
a super
Genetics
specialty.
comes
It is.
genetics comes later, but the important thing is papillary microcarcinoma. Active surveillance is accepted, equally effective. low risk tumors, thyroid lobectomy is accepted. For high risk tumors and tumors beyond 4 centimeters and things, total thyroidectomy. So only
Those are all
two
very
things.
important.
So total lobectomy, total thyroidectomy. Only 2 surgeries now. Lymph node is based on clinical evaluation, radiologic evaluation. If you can even do an FNAC of the node, if you feel they are, if for example the radiological characteristics are similar to the nodule characteristics, taller than wider, loss of the corticomedullary differentiation, increased vascularity, matting of the nodes, all of these, size more than 1 centimeter, all of these things. So if there are clinically positive or radiologically positive nodes, you can even do an FNAC of that and then plan your treatment. So if there are nodes positive, nodes enlarged at least, then you can do a central node dissection on that side of the nodule, and then based on that you can then further treatment can be done. So
Can you
surgery,
do node dissection based on ultrasound finding of the nodes?
yeah, you can. If for example, if the radiologically, if they are, the characteristics I just mentioned, you can do a, neck dissection, that is central compartment node dissection, you can do.
Sir, I have a doubt.
Yeah.
Like they said, suppose if we are not exposing the patient to an iodinated contrast, but in spite of that, we need to find out the extrathyroidal extension and the nodal status through CECT. What other contrasts can be like?
You
You
can
can't
see
use-
CT scan, no?
You don't need any other. So what you do is ultrasound will be able to tell you most of the time. All the
Okay, sir.
information that you need, ultrasound is very good. If there is doubt, then you do a non-contrast enhanced CT. That will tell you everything that you need to know. So
Okay, sir.
then after that, you can use the radioiodine in the post-operative phase to identify if there are any residual tumor in the thyroid bed or if there are distant metastases.
Okay, sir.
At this point, Nikita, you should know the radiological manifestation of metastatic lymph nodes versus benign lymph nodes.
Yeah. So
Okay.
I've actually listed it out.
Yes, sir.
Okay. I think I will share the PowerPoint presentation with all of you. It is important for you to go through this because I think it is most of the slides are self-explanatory. So you will be able to revise this for your exams and also for your day-to-day practice.
Yes, sir.
Tanya and Nitya, questions, comments?
Sir, it was a very nice class, sir. Like, whatever is needed, it was properly covered, sir. Like, I think we should keep going through this so that it is, and it is all latest updates. So it's very useful, sir. We'll keep going through this presentation again as well, sir. It's very useful.
Most of the data are even 2025 data. Whatever I have told you is completely scientific and it's just backed up with proper data, not some statement that is made. Tanya,
I agree with Nitya, sir. Very extensive, very nice class in detail about everything that has to be known.
Srikanth, final comments. Niranjan,
Yeah,
final
yeah.
comments.
Excellent class. I don't think examiners will not ask anything more than this.
Yeah. Hopefully.
Sir, it was very good, sir.
Thank you all. If there are no further comments, the last slide. The past is behind, learn from it. The future is ahead, prepare for it, and present is here, live it. So that means we should know what is coming. That is what we have talked about NGS and all that. The past, we know what we were doing, and you have to now do what is current, which is what I have talked about today. Thank you. Good night.
Thank you, sir.